Welcome to This Explainer. Today, we're diving deep into a MedNexus breakdown on diabetes mellitus. It's honestly one of the most complex, widespread, and, well, fundamentally important chronic diseases in modern medicine. Let's just jump right in.
So what exactly happens when the body just completely loses control over its blood sugar? We hear the phrase high blood sugar thrown around all the time, right? But the physiological reality is that unchecked glucose doesn't just sit around quietly. It literally wreaks absolute havoc on the system.
To give you a quick roadmap, here's our agenda for this explainer. We're going to cover the baseline physiology, the exact cause in type 1 versus type 2, the classic symptoms, the acute and chronic complications, diagnosis and treatment, and finally some high-yield pearls.
All right, let's start with section 1, the baseline physiology. Okay, so think about what happens right after you eat a meal. Your blood glucose naturally spikes, and in response to that, the beta cells in your pancreas, specifically hanging out in those islets of Langerhans, release insulin. Now, you can think of insulin like a master key. It actively unlocks your cells so they can pull in that glucose and use it for energy. Plus, it promotes glycogen synthesis, fat storage, and protein synthesis. The end result? Your blood glucose levels safely drop back down.
But diabetes? Well, diabetes represents a total collapse of this beautiful regulatory system. By definition, it's a metabolic disorder characterized by chronic hyperglycemia, meaning your blood sugar is persistently high. And this happens because there's a defect in either the pancreas actually secreting the insulin, the body's cells responding to it, or sometimes a combination of both. So all that glucose is just left stranded in the bloodstream, completely locked out of the cells that desperately need it.
Which brings us to section 2, the cause, specifically type 1 versus type 2. These two are fundamentally different. In type 1, which usually hits suddenly during youth, your own immune system turns against you. It literally attacks and destroys its own pancreatic beta cells, a process often marked by the presence of anti-GAD antibodies. This leaves you with an absolute insulin deficiency. The factory is just shut down. Type 2, on the other hand, is a totally different beast. It's primarily an issue of insulin resistance. Your pancreas is still churning out insulin, but your cells, they're completely ignoring the signal. This form is heavily linked to obesity, a sedentary lifestyle, and aging, making it the most common form by far. Oh, and we definitely need to mention a third category here, gestational diabetes. This occurs during pregnancy, and importantly, it drastically increases the mother's future risk of developing type 2 down the road.
Moving on to section 3, the consequences, or the actual symptoms.
So when your blood sugar gets incredibly high, your kidneys just cannot filter it all back in. The excess glucose inevitably spills right over into your urine. And because glucose is an osmotically active molecule, it drags massive amounts of water right along with it. We call this process osmotic diuresis.
And this massive water loss perfectly explains the classic 3 Ps of diabetes. You've got polyuria, which is frequent urination, polydipsia, or extreme thirst to make up for all that lost water, and polyphagia, which is intense hunger because, remember, your cells are literally starving for energy. Patients will also often see unexplained weight loss since the body is forced to start breaking down fat and protein just to survive. Throw in some profound fatigue, blurred vision, and skin issues like poor wound healing or recurrent fungal infections, and you start to see the full clinical picture.
All right, section 4, acute and chronic complications.
For acute crises, you absolutely have to remember the split between these two major emergencies. First is diabetic ketoacidosis, or DKA, which mostly strikes in type 1. Since there's zero insulin, the body panics and rapidly breaks down fat, pumping out huge amounts of ketones. This throws the patient into a dangerous metabolic acidosis, complete with deep Kussmaul breathing and this distinct fruity breath odor. Then, on the flip side, you have hyperosmolar hyperglycemic state, or HHS. This one mostly hits in type 2. Here, there's just enough insulin floating around to prevent ketosis, but the blood sugars still get astronomically high, leading to severe, profound dehydration.
Let's pause on this quote for a second, because it really captures the insidious nature of chronic hyperglycemia, a disease that begins with abnormal glucose metabolism, but can silently damage your eyes, kidneys, nerves, blood vessels, heart, and even your brain. It's like microscopic sandpaper just silently running through your vascular system over years and decades.
And this silent damage ultimately manifests in 2 massive ways. First is microvascular damage, meaning the tiny blood vessels. This gives us diabetic retinopathy, which is actually a major cause of blindness, diabetic nephropathy, a leading cause of chronic kidney disease,
and diabetic neuropathy, which causes severe numbness, tingling, and burning in the feet. Second is the macrovascular damage, affecting the large vessels. Diabetes dramatically accelerates atherosclerosis. This means a hugely increased risk for heart attacks, strokes, and peripheral artery disease. And when you combine that severe neuropathy with terrible blood flow, you get the dreaded diabetic foot, which so often leads to severe ulcers and, unfortunately, amputations.
Now for Section 5, Diagnosis and Treatment. Let's look at how we actually fix this.
First up, lock this number into your brain. A fasting plasma glucose greater than or equal to 126 milligrams per deciliter is officially diagnostic for diabetes mellitus.
Next is the HbA1c. This is a brilliant lab test because it reflects a patient's average blood glucose control over a full 3-month period. For this one, the diagnostic threshold is 6.5% or higher. And finally, if a patient comes in with a random blood glucose test of 200 or higher, and they're showing those classic symptoms we talked about, like the polyuria and polydipsia, well, that firmly confirms that diagnosis too.
Once we've got the diagnosis, treatment management is key. It absolutely always starts with lifestyle modifications. Diet and exercise are crucial here and can actually prevent many cases of type 2. From a pharmacology standpoint, insulin therapy is, of course, literally essential for survival in type 1. But for type 2, your absolute first-line drug is metformin, which works beautifully by decreasing hepatic glucose production. Beyond that, we have an amazing toolkit of medications, like sulfonylureas, SGLT2 inhibitors, and GLP-1 agonists that can force the kidneys to excrete glucose or really help with weight loss and glucose control.
All right, let's wrap this up with Section 6, High-Yield Pearls.
Before you go, you're definitely going to want to mentally screenshot this table. Let's rapid-fire the core concepts. Insulin action directly leads to decreased blood glucose. A severe drop in insulin, that drives the massive ketone production we see in DKA. Glucosuria is the direct physical driver of polyuria thanks to osmotic diuresis, and metformin, that is your absolute go-to primary drug for type 2.
Diabetes mellitus is a massive topic, but grasping this baseline pathophysiology is absolutely essential. We've literally seen how a single missing key, insulin, can cascade into this systemic, life-threatening organ damage. So, I hope this explainer was helpful, but it leaves us with a really provocative question as we wrap up. As global rates of type 2 diabetes continue to just skyrocket due to modern lifestyle factors, are we treating a disease, or are we fundamentally treating an environment? Think about that as you continue your clinical studies. And let us know, which endocrinology topic should we tackle next? See you next time.